Hello everyone. This is the first lecture to cover some content about quality and safety and also clinical risk management. So let's start with looking at this statement. Every healthcare practitioner and every healthcare institution has two major objectives. One is to provide care of the highest possible quality. Another one is to provide care to at the lowest possible costs. Take a couple minutes to think about what this means. That means, what's the obligation that we have as service providers? And what's the obligation we have as a service provider with a financial constraint and also the pressure of inadequate financial resources and also meeting the increased needs and demand in the population. So think about what that means and the implication to us as practitioners in providing the level of care in consideration of the limitations that organizations are all facing. So what is quality? The subject is about healthcare quality, and it makes sense to start with defining what quality is. So just a couple of examples, a few examples, how different organization resources that define quality. Look at the Institute of Medicine. Quality is the degree to which health services for individuals and the population increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Or look at the World Organization of Family Doctors. Quality means the best outcomes possible given available resources and the preference and values of patients. So it not only looked at the best we can provide, but also look at what the patient's preference are, and also in consideration of the limited resources we have. And the Australian Council of Safety and Quality in Healthcare define quality as the extent to which the properties of a service or product produces a desired outcome. So that means quality means by what we're doing, the extent that the outcomes that we produce as planned. Look at the Institute of Healthcare Improvement. It says quality is the dimensions of performance of a system that the people who depend on that system care about. So it defines quality based on people's perspectives, people's preference, and also the performance of the service they provide to the people that they serve. So there's a different way of defining quality. However, according to the quality framework, you look at quality from 6 different dimensions. I have to say is that different state department and different system may adopt different quality framework, but there are similarities. And this is a 6 dimensions. Majority system will place specific focus on. One is safety. So the service provides is safe. It doesn't cause harm. Accessibility. So you have the service, but it doesn't create barriers, obstacles for people to attend to. So you have the service, people can access to the service, regardless the race, culture, age, whether they're healthy or whether they have disability. The third dimension is efficiency. So what is efficiency? It needs to consider with effectiveness. So let's explain what effective means before we can understand efficient better. Effective means our actions do produce the desired outcomes. So if the actions aiming to create such level of outcomes, this amount of outcomes, then if we can produce that, they will say our action effective. So you go and see a doctor and aiming at releasing the pain that you have, or curing the symptoms that in presentation. And after seeing the doctors, after the treatment, all those are gone. So I would say the intervention the doctor provides or the treatment doctor provides is effective. But what if efficient? Efficient need to consider most the outcomes that you produced and the resources that you consume. So it's not only that your actions lead to the creation of the desired outcomes, but also it costs less resources as required, or at least do not cost more resources as required. So there's two typical scenario will be the same amount of resources you produce high level of desired outcomes, or you produce the same level of desired outcomes with less amount of resources required. Appropriateness. So the services provided to patients are relevant and appropriate to their groups. Consumer participation or acceptability, it looks like two different things, but if when you design services without contribution or listening to the consumers, and the level of acceptability of the services may be compromised. In the last 20, 30 years, we started to pay more attention to the importance of having consumer participating in the care, in designing the care. So the sixth dimension is about consumer participation, how well our service providers engage consumer in designing the service or determining the type of service and nature of the service that we provide to our consumers. So these are 6 dimensions of quality that we need to pay attention to. When it looked at not just quality, but the quality of care, we look at that in 3 different components, especially when it comes to the system level and organization level. One is the structures, so how this care, how the organization, how the system is structured, in what way, in meeting the needs of our population, that allow the best use of resources, through what process those cares are provided, and what the level outcomes that we'll be expecting to the patient and the community. So when you look at when we measure the quality of care, we measure them through the structure and the process and the outcome. Because without the consideration of structure and process, the outcome might be compromised. So let's look at, we talk about quality and safety, and look at how we define safety. Safety, and this is a couple of definitions that I captured from 2 different resources, and look at the Australian Council of Safety and Quality in the 2006, now it's called Australian Commission on Safety and Quality in Healthcare Service. It defines safety as the degree to which potential risk and unintended results are avoided or minimized. Okay. Is quality and safety something new? This is a tricky question. When you review the educational curriculums in the university system, you noticed only the recent 10, 15 decades or decade and a half, we started to have a formal subject to cover quality and safety more systematically. So is quality and safety is not a concern in healthcare? Of course not. But why suddenly we pay particular attention to quality and safety when all other sectors have regulations tightly control the perspective of quality and safety? But why not healthcare in the past, in 20-something years ago? There's many reasons that make healthcare extremely risky to patients or also to the service providers themselves. And we may have talked about quality and safety, but however, it's not in a systematic way in looking into it until something actually happened. So we call the real trigger. Unfortunately, a lot of time the real triggers are about the scandals and about the adverse events that happen. That not just happen once, but repeatedly happens. That caused concern and caused investigation, then caused the learning to take place. This is just an example. When you have time, you can Google those cases. These are the high-profile scandals in the public hospital and private hospital systems in the UK, in New Zealand, and in Australia. And most recently is the St Vincent hospitals between 2012 and 2015. There's much more. And the question is, the first biggest healthcare scandal is the Bristol Royal Infirmary. That was nearly 20-something years ago. Why we haven't learned? Why things are still repeatedly happening in other parts of the world and in Australia as well? Not just because the healthcare is a really complex system, but also there's one thing, is we don't deal with situation well. When things happen, we deal with people. We may be terminate the task, but we do not investigate and understand the situation that caused these adverse events and unfortunate situations that cause harm to the patients. And we haven't learned fast enough in healthcare. And when you look at all those reports, common questions normally we ask. First we ask, what happened? Then we need to know, how did we respond? Did we respond fast enough to prevent or to stop adverse events happen or stop further damage and harm to patients? And then we will ask, what changes have we made as a result? Have we learned? Have we avoided it in the future? Have we put in place strategies to avoid similar situation in the future? A lot of time the answer is not quite. And then we will ask, what common strategy have we adopted to addressing the issues? By asking those questions, we started to explore the real reasons, the root cause of all the problems. And most importantly, we need to make sure they adequately learned from the mistakes made. When you look at the major issues behind all those high scandals, we can actually categorize them into three different areas. One is about policy, governance, and leadership. One is the performance monitoring and measurement. Another one is responsive system. These are the three major areas that we're not doing well that cause repeated scandals in the system. When it comes to policy, governance, and leadership, common reason that cause the problems are lack of system-wide planning and clinical leadership. Clinical leadership is not just about managers taking a leadership role, but service providers, health professionals, they are taking the real responsibility to ensuring the services they provide to patients and customers are safe with high quality. And all levels, all levels within the organization, including the system level, they are sharing the same responsibility of quality and safety care. And there's a lack of legislative protection to whistleblowers, lack of risk management policy and procedures, absence of clinical governance. Although clinical governance is no longer new in Australia and then has been implemented into the majority of the public hospital systems, however, have we actually adequately used this clinical governance framework to guide quality safety care? And that's the question we need to investigate further. Are we just using the framework as a decoration in our policy menu, or are we actually using this framework to deliver high quality care? A lack of organizational commitment to quality and safety from board and senior management level, no commitment to build a culture of trust and honesty through open disclosures with staff and on consumers, so people reluctant to share the concerns. And also, there's no lack of transparency of the responses and actions taken by the senior management in responding to the report and concerns that raised, and also an issue. There's a lack of support to staff in providing high quality care, and also there's consistent organizational and senior staff instability. The high turnover, burnout is quite common in healthcare, especially in the senior management levels. So frequent change in leadership and senior management create instability within the organizations. So some quality initiative might be implemented and without being followed through before the management's change. The second category of issues in healthcare is performance monitoring and measurement. This includes failure to monitor performance, failure of senior management to respond to important safety and quality issues, and a closed culture unsupported to openly disclosing errors and adverse events. You look at this from two different perspectives. One is failure of senior management to respond to important safety and quality issues. That could cause to the reason could be lack of data information that draw immediate attention of senior management, that prompted them to realize there are issues to address. One. Second is lack of awareness for the senior management of the importance of responding to the issues as reported, and lack of clear procedures and structure for management to follow. So the other issues about the culture that is not supportive. So people reporting the errors and the issues, but the reactions and the actions are not transparent, and the actions as a result are not measured. So it's not unclear to staff and consumers what's the outcomes of reporting. Therefore, open disclosure now become a public policies in the Victorian healthcare system and in other states as well. There's unclear clinical audit and peer review systems. We do have clinical audit processes. However, what type of clinical data is collected that reflect the true quality and safety of service providers, and different service providers and now benchmark is still not consistent and not 100% transparent. A lot of time indicators are collected for the purposes of reporting rather than the purposes of quality and safety improvement. This absence of credentialing and privileging. There's significant improvement in Australia in the last 10 years in this regard. Inadequate structures, systems, and processes in place to rigorously and identify, monitor, and evaluate care. As I mentioned before, when you don't know what data to collect, what performance indicators best reflect the quality and safety care, then how are we going to monitor and evaluate the care? And how are we going to monitor and evaluate the actions as a result of the changes? And also the lack of responsiveness of the system. There's poor communication processes. Communication should be top-down and bottom-up as well, not just senior management telling frontline staff what to do, but also senior management responding to the report and concern from frontline staff. They are there's an encouragement of two-way communication and encouraging the best effective channel for information exchange, allowing quicker action response to made. There's inadequate budget allocated to quality and safety improvement, including professional development to the staff and management. Failure to act on complaints. Sometimes complaints being ignored. Sometimes complaints being deliberately hidden from the public. because of the implications. Sometimes it's just lack awareness what level can place that means are serious concerns. There's tendency of administrators to ignore or suppress criticism. It is important. I think we are human beings. We all make mistakes, and also we sometimes respond to our emotional stress. However, when a good system and structure is in place, we should be able to minimize those human errors and allow a more supportive culture and environment that encourage reporting, encouraging feedbacks. This organizational performance is only based on financial issues instead of all aspects of clinical governance. So managers should not only look at financial performance, keeping the budget sheet balanced, but also looking at the quality and safety improvement, because by the end of the day, improving quality and safety in the long run will save costs. Not only saving costs to the organization, but to the system, healthcare system as a whole. And in Australia, the public hospitals are funded based on case mix funding models, that it will make sense. The better quality and safety the service will provide, the better balance sheet that the hospital will keep, because the low quality and safety service will lead to complications, lead to adverse events. The hospital will not get funded by the additional service they provide. So under the new funding model, should be able to see, and we have seen improvement in service provisions in terms of quality and safety. So the changes that we have witnessed, not just in Australia, but around the world, that's including developing quality and safety indicators. It's worthwhile to look at the quality and safety indicators that we use to measure public hospitals in Australia, which we'll cover that later on during the semesters, and better reporting and data collection systems. And it is one of the obligations for receiving funding or for getting accreditation by public hospitals now is to collecting the set data and the report on an annual basis. Establishment of quality and safety authorities in the country level, learning and adopting product quality management models from businesses, such as the terms that we can frequently hear in healthcare setting now, such as standardization, standardized procedures and protocols, quality control and assurance, continuous quality improvement, performance benchmarking. Yes, this is not new to healthcare. However, this is a good example of how we learn from other businesses. Implementation of clinical governance framework is no longer something new now, but it was quite new 10 years ago. And national quality and safety health service standards and accreditation. So this is something that we have seen as great changes, positive changes happen in the healthcare system. But as you know, we still see adverse events. We still cause harms to patients unnecessarily, and which are preventable. The question we should keep asking is, can we do better? Or yes, we can do better by taking a number of steps, which we should look into it throughout the semesters. But first, we need to have a better understanding of why we talk about risk in healthcare. What is risk management? To avoid adverse events, to improve quality and safety, the first step is to understand what the risk that we are facing in providing the care and how we minimize the risk. First, how we avoid the risk, how we minimize the risk, how we minimize the negative impact of the risk. What is the risk management and process? What's the key quality improvement approaches? What's the effective risk governance? And what's the characteristics of a resilient organization? Now, this is the 5 questions for you to think about before I record the next lecture, and which will be available in a couple of hours. But in the meantime, I would like you to think about this before you access the other recording.